Good afternoon, everyone. On behalf of Ahmedabad Family Physician Association, I, Dr. Dhirendra Sanandya, President of AFPA, welcome you all in webinar going to be live on our own YouTube channel. With me on Zoom meeting, our eminent speaker, Dr. Shailesh Darji and Dr. Rajeev, and as a moderator, AFPA past President, Dr. Viral Khama. Also with us from Johnson & Johnson Pharma, Area Manager Harish Trivedi, Harish Chelani, and Devang Jasani is also with us. Before starting the CME lecture, one message to all the APA members that all non-emergency and non-COVID services to be closed down from 6 a.m. to 6 p.m. on 11 December, tomorrow Friday, in support of fight against the mixopathy. So please join in strike tomorrow and make it successful. Now I request Dr. Viral Khama, moderator, to give brief introduction of our speaker, Dr. Shailesh Darji. Dr. Viral Khama, please.
Okay. On behalf of AFPA, I welcome all the participants and today's speaker, Dr. Shailesh Darji and Dr. Rajeev Harshe, and representative from Johnson & Johnson Private Limited. It's my pleasure to brief about Dr. Shailesh Darji's achievements as well as clinical interest and expertise. Dr. Shailesh Darji is a renowned neurophysician at Care Neuro Clinic, Papunagar. He won the first prize in the West Zonal Doctorate Young Scholar Award in 2013 for neurology. He also won the first prize in the neurology competition held in Chennai during Shine 2014, 4th Annual Conference of Clinical Neurology. He also won the Professor C.P. Munshi Best Paper Award at 27 All Physicians of Gujarat Conference in 2007. He has good clinical experience in managing various neurological emergencies like acute ischemic stroke, status epilepticus, acute confusional state, movement disorders, emergency, and acute muscular weakness. He has experience of 30 successful IV thrombolysis in acute ischemic stroke. He has vast experience in electrophysiology related to neurology, including EFG, EEG, NCV, and VEP. He has 5 years of experience in critical care as a critical care physician. This critical care physician experience makes him outstanding among all the neurophysicians. I welcome Dr. Shailesh Darji to start his talk on approach to headache from general practitioner's perspective. Thank you. Dr. Shailesh Darji, please.
Thank you, AFPA, to inviting me for this interesting session on headache. And thank you very much for warm welcome. I am going to start with basic approach to headache. Let us see.
Yeah.
So headache is very common, but it is very unknown entity. Many times we experience headache in our life. I think 90 to 95% of person might have headache once in a lifetime. It is very important to know what is headache, but it is still unknown. Like previously, there was a like example of Maggie was there. It was banned because of it was inviting migraine-like disease, and which is a chronic neurological disorder involving headache and other symptoms. So it is very well known that Maggie can lead to migraine, and it was withdrawn from the market. But still, we are very much unaware about headache. So let us go further. So headache is a common problem in India as well as elsewhere in the world. Given the population load and the fact that most headaches seen in practice are underdiagnosed and undertreated, the burden of headache is very significant. And in this modern era, when imaging studies are easily available, most secondary headaches are identified. But what about primary headaches? So this is very important difference. Whenever person come to neurologist in clinic with having headache of any duration, like duration of 1 day, 3 days, 5 days, or 10 days, or months or years, then what our main target is to find out whether it is a primary headache or secondary headache. Many times what happens that patient have headache and he went for neuroimaging, like directly land into the MRI center and get MRI done. But after MRI, if there is some tumor or some any abnormal finding in the MRI, then it will go into the secondary headache. So it is very easy to diagnose secondary headache by going for MRI brain. And but if MRI is normal, MRI is negative, there is nothing in MRI, but still patient having headache, then there is always confusion start. And those are headaches which are known as primary headache, when you are not getting anything in the investigation. And mind well that 90% of the headache are primary headache. So 90 to 95% of patient having headache is always primary headache. Sometimes there is some worry in the patient that if headache is there, then there will be a brain tumor. It is not like that. It is the chances of having brain tumor is 0.1%. So let us continue further. So as I told that headache is very common, 75% of the population per year, and 25% of the neurology OPD is headache. Daily headache affects 4% of the population. On any day, 90,000 people are absent from work or school because of headache. Migraine alone accounts for 20 million lost work or school days per year. So cost of migraine to the economy of country is huge. So we never thought about migraine, but really it affects very good amount of social functioning. Like a migraine patient have many times avoid social functioning, like attending marriages or many other things. So it is very important that headache is very important in our life. In India, we are looking about TB, HIV, poverty, literacy, economic burden, but headache is above all. So headache is very important entity to understand in India also. So as per international classification of headache, there is basically a primary headache is divided into four main etiologies. That is, most common is migraine, second is tension type headache, third is cluster headache and other trigeminal autonomic cephalgia, and other primary headaches which are not of these three types. It can be anything like cough, exercise, sexual, cold related headache. So all these headache are primary headaches. So they must have characteristic of benign features without abnormal neurological signs. So this is very important. And these are the classification of secondary headache, where you get something in the imaging, something in ENT workup. There might be some fever, some infection. There might be some disorders of homeostasis. There might be some substance withdrawal, some drug effect, or any type of things like psychiatric disorder or some trigeminal neuralgia like condition. So these are all secondary headaches where you get some imaging finding or some other important findings. So we will go further. So in India, secondary headaches are also frequently seen, which having etiology like tuberculosis, neurocystic sarcosis, meningitis, cerebral venous thrombosis, benign hypertension. So these are all the common causes of secondary headache. This is the patient with venous sinus thrombosis. Mind well, this patient can present with history like migraine, but there are subtle differences that we have to find out. So we should never miss this type of headache in our OPD clinic. This is the headache associated with brain lesion, which is likely to be a meningioma, leading to change in the optic nerve also. So which are the flags, red flags? So whenever you are sitting in the OPD and you are looking a headache patient may have headache for 2 days, 3 days, 5 days, 10 days, maybe 1 month. But mind well, these are the red flags which we have to understand. First, most common important thing is systemic symptoms. If patient having fever or weight loss or any systemic symptoms, then we should consider that it may be a secondary headache. So understand, you have to only find out whether it is primary or secondary, So if you go through all this list, that is known as SNOOP, then you can understand that it is a secondary and otherwise it is a primary. So secondary risk factors like patient having underlying etiology like HIV positive patient, immunocompromised patient, patient on steroid because of rheumatoid arthritis or any other disease. See, patient on steroid can catch any infection directly, like tuberculosis can happen in steroid patient. So this is very important. Then cancer, sometimes patient may hide the history of HIV or cancer. Patient may not tell you that I am HIV positive. So we have to find out whether it is HIV there or not. So many times it happens. Neurological symptoms or abnormal signs may be there. Patient tell that I have a feeling of imbalance, I have visual blurring, So these are all symptoms which are not seen in primary headache. Then if patient having a new onset, acute onset headache, if patient having history of 3 days of headache, then it is very important that it might be secondary headache. Then older patients, always remember that if patient came with first time of headache after 50 years of age, then it is more likely that it is a secondary headache. So never miss that. Age is very important. Then previous headache is different from present headache. Sometimes it happens that a around 40 years female may present with a new onset of new pattern of headache, which was previously a migraine like, but now it is a different pattern. Then it may be venous sinus thrombosis or something else. Then positional component, if it is there, then provocative factors are there, like increase with coughing, exercise, sex. So it also suggests posterior fossa lesion. So this is very important snoop. Now these are the danger signals with headache, like first and worst headache of life, loss of consciousness, collapse, focal neurological signs, fever, sudden onset of headache with vomiting or loss of consciousness, neck stiffness, new onset headache after age of 50. So understand why I'm telling this. That many times it happened that patient came with a headache history since 3 days. Patient tell that, sir, મને 3 દિવસથી માથું દુખે છે, આની પહેલા ક્યારે કોઈ તકલીફ નથી થઈ. But this is very important to understand that female patients sometimes never tell past history. 3 days of onset, that it is tell as first and worst headache. See, understand that this is the first onset of headache, which is only 3 days. So then you always think of MRI brain to find out any secondary headache. But it is not like that. If you go in a detail on history, તમે પેશન્ટને પૂછો કે ક્યારેક તમે મેરેજ પ્રસંગ હોય, ક્યારેક ઉજાગરો થયો હોય, ક્યારેક ભૂખ્યા રહ્યા હોય તો માથું દુખે છે, then patient tell, હા સાહેબ ત્યારે તો હું દુખાવાની ગોળી લઈ લો, એ તો સામાન્ય દુખે છે, એમાં કશું હોતું નથી, પણ ક્યારેક ક્યારેક દુખાવાની ગોળી લઈ લો, સ્ટોપેક લઈ લો, સૈનિક લઈ લો, બ્રુફેન લઈ લો ને મટી જાય. So this history shows that patient have chronic headache. This is a migraine, and presently also this 3 days headache is migraine, nothing else. But patient may understand that that was some common headache, but it is actually a migraine. So it is very important and very technical thing to find out in OPD, that whether there is a previous history of migraine is there or not. પછી તમે પેશન્ટને પૂછો કે અત્યારે જે માથું દુખે છે ને જે જૂનું માથું દુખતું હતું એવું સેમ જ છે કે કંઈક અલગ છે, તો પેશન્ટ કહેશે કે ના સાહેબ એવું જ દુખે છે, પણ ખાલી અત્યારે થોડો દુખાવો વધારે થાય છે અને પેઇન કિલરથી આરામ નથી થતો. So that means that it is a migraine only, there is nothing else. And recently in last 6 to 8 months, I have seen many migraine patients increasing in my OPD, maybe because of increased intake of lemon. So patients are taking lemon juice for COVID-19 immunity and limb C, vitamin C. These are all citrus products, and they may lead to increased episodes of migraine headache. So 10 to 20% increase in my OPD I have seen in last 6 months of migraine patients. Sometimes, as I told, that more than 50 years of age, if patient present with unilateral headache, then we have to rule out temporal arthritis. This is the condition which is very important. If you don't diagnose it early, patient may lose vision in one eye because of involvement of the ophthalmic artery. So these are the few secondary headaches. Now, as the COVID-19 pandemic is going on, I would like to also tell few points on the COVID-19 also. It was seen that headache can be the isolated symptoms of COVID-19. So COVID-19 સાથે પણ patient headache સાથે આવી શકે છે. Always understand, and that headache is also like migraine. So patient ને 2-3 મહિના પહેલા COVID થયું હોય તો પણ migraine type symptoms એને develop થઈ શકે છે. So always remember that COVID-19 is very important cause of headache, and sometimes it mimics migraine and take recovery for several days. And sometimes there is some unusual features like rapid onset, higher intensity, maybe associated anosmia, ageusia, loss of taste and smell is very important. There might be some diarrhea, reduced appetite, weight loss, and partial response or temporary recovery lasting hours following use of analgesics. So COVID-19 is one of the differential nowadays in our OPD when patient having headache. And it was shown in one study that 10% of COVID positive patient might have headache, which is very moderate to severe and need evaluation. And sometimes COVID-19 with headache may have thrombotic or hemorrhagic stroke in the brain, venous sinus thrombosis, encephalitis, or some drug-related side effect. So never misdiagnose or misunderstand headache in COVID-19 patient. So now let us go briefly about diagnosis. So whenever we think about headache, we always think about MRI or CT scan, but it is not like that. Almost primary headache are diagnosed on the almost entirely on the patient's story. So we have to listen to the patient's story. So listening is the art in neurology. Patient tells story about his or her headache for 15 to 20 minutes, and we listen and we diagnose that which type of primary headache is there, whether it is a migraine, whether it is a tension type headache, whether it is a cluster headache, or what type of headache. So story of headache particular is very important in OPD practice. Sometimes patient went into fancy workup like X-ray skull, but it is useless investigation. So in history of the patient, pattern recognition is very important. I will briefly go to the things how to determine primary headache. So in migraine, the most important aspect in history is how long does it last. So duration of the individual episode of headache is very important. See, understand primary headache is most of the time it is episodic in nature. In neurological disorder, the disorders can be two types. One is episodic and one is continuous. So when patient having a stroke, then the weakness is continuous. It will remain for lifelong maybe. In same way, some illness are episodic. Like in stroke, there might be TIA, that is transient ischemic attack. When episode of TIA is happen for 1 hour, 2 hour, or 1 day. So same way in migraine or any type of headache, patient may have episodic illness or continuous illness. So most of the primary headache are episodic in nature. So migraine episode will last for 4 hours to 3 days. So this is very important in the history. When patient tell that headache starts and it increasing gradually, and after 4 hours there is a severe headache, and it may last up to 3 days. So 72 hours is the duration, and it is moderate to severe pulsatile throbbing type of headache is very important, and it can be one side or two sides or whole head. So this is very important in migraine. There might be as well aura, nausea, vomiting, sensitivity to light, sound, smell. It can happen in migraine headache. So most of the time, typical migraine patient is teenager, child, or young adult, but it can start at any age. I have diagnosed migraine in more than 60 years of age of the patient also, and it is more common in women. And typical patient is young women, 15% of all young women. And this is the classical book picture of how migraine starts and what happens gradually. So understand that migraine is basically a familial condition. It is strongly inherited. And there is a lower threshold to spontaneously produce symptoms as if the head and brain had been injured. Many effective treatments are there. And there is some vascular and neurological theory for that. So most important thing to know in migraine is triggers. So whenever there is a triggers, there is a migraine attack. So triggers can be foods, lack of sleep, stress, and sometimes hormonal imbalance like menstruation or during periods. And sometimes intake of coffee is also associated with migraine attacks. These are the typical triggers of migraine in our Indian setup, like stress of education, high pollution, humidity, heat, incense sticks, henna application, spicy oily food, most of the citrus food, lemon juice, festival, crowd, noise, hot climate, poor travel condition, joint family stress. So these are all 70% of female having a stress associated with migraine episodes. Now, I will go briefly on tension type headache. So understand tension type headache duration is very variable. It can be 30 minutes to 7 days. So it is a very longer lasting headache, and there will be a band-like sensation. There is no throbbing. In migraine, there is a throbbing. Here it is a band-like, pressure-like sensation. Tightness will be felt, and often it is daily headache. And there will be a no light sensitivity, sound sensitivity, no aura. And this type of tension type of headache is classically seen as a band-like around the forehead or side of the neck or nape of the neck. So these are the various areas of tension type headache. So I have seen many times that tension type of headache patient misdiagnosed as a migraine, and it may happen. So migraine treatment will not be applicable in tension type of headache. There is a different treatment for tension type of headache. And many times tension type of headache is associated with anxiety, depression, or such type of psychological things. And cluster headache is also very important primary headache, which is oftenly misdiagnosed as migraine. Here the duration of attack is hardly 15 minutes to 3 hours. So it is less than 4 hours. Understand the migraine duration is 4 hours to 72 hours, while here duration is less than 3 hours. And cluster headache is always unilateral, one-sided, very excruciating, very severe pain. Migraine કરતા આનું પેન 10 ગણું વધારે હશે અને પેશન્ટ ધમ પછાડા કરશે because a patient will not sit at one place. It starts moving here and there because of this headache. And the classical diagnosis in cluster headache is giving oxygen by inhalation. 8 to 10 liter oxygen will subside this headache within few minutes of time. but this is not possible in our Indian setup. So we rely on history only, and it is preceded with smoking or beer intake. So and lack of sleep. So this is about cluster headache, and there is also associated with autonomic manifestation. So this is what location of cluster headache. That is a periorbital region and on the one side of head, and periorbital region. This type of pain is patient આવી રીતે જ બતા કે સાહેબ અહીંયા દુખે છે, like that. This location is very important around eye. This is never seen in migraine કે ખાલી eye pain થાય અથવા eye ની આજુબાજુ થાય. Migraine might have whole cranium, many more area in migraine, but it is always periorbital in nature in cluster headache. So I have seen that cluster headache patient may attempt suicide because sometimes the cluster headache diagnosis can take few years because the episodes are once in a year. There is an episode which lasts for 30 days to 45 days every year, and then patient is all right in between. So 3 to 4 episodes may be there in last 4 years, and it never diagnosed by physician or any local doctor. So when we take history, we also ask for past history of similar type of headache, and then we come to know that it is a cluster headache. So then many years can be passed when the diagnosis of cluster headache is there, and that's why patient feel very difficult and problematic. And there is one another entity, that is trigeminal autonomic cephalgia. In that differential is a paroxysmal hemicrania and shunt. We will skip this thing. So I want to highlight this medication overuse headache also. Sometimes it happens that migraine patients start taking analgesics, and I have seen patients taking Shailesh or Stopac daily, and these patients are headache made worse by painkillers, only occurring patient who already had headache, mainly due to codeine containing medicines or stronger morphine-like drugs. I need to stop responsible medicine, easier said than done. So these type of patients are very difficult to treat. They are known as complicated migraine, and they need regular follow-up and to decrease abuse of this painkiller drug. Okay, now as I told previously that examination, the most important aspect in examination in OPD practice is to rule out papilloedema by fundus examination, which we are not doing at present due to COVID-19. But this is very important to see the fundus. Then blood pressure checkup and general neurological examination is very important. Sometimes you have to take proper neurological examination to find out subtle neurological signs. And most of the time, investigation are not necessary in primary headache. ESR CRP can be done to rule out temporal arteritis, and MRI CT scan, as I told. So when you indicate, when you refer patient to neurophysician or any higher specialty, when secondary headache is suspected, when you obviously see tumor in the brain, you have to refer to neurosurgeon. So it is obvious reason. Clinical features suggest significant or serious neurological disease. If you feel that patient might have something other than migraine or primary headache, failure to respond to appropriate adequate treatment, patient at high risk of serious disease, reassurance, and unusual headache pattern. So these are the many indications for referral to a neurophysician or neurosurgeon. So management is very important. I will briefly take only 5 minutes for this management. There is one question I get into WhatsApp. How is your headache? So a patient tells she is sleeping. So actually she was telling about her wife. So this is very common history in OPD practice that patient often say, I am tired of going to the same doctor with the same complaint only to be given the same painkillers with the same headache persisting. So this is the very common history of migraine patient, that many times it advised Brufen or Shailesh or something like that, and painkiller was there. Will go, many painkillers are there, but patient take this painkiller for long run, but there is intermittently patient may feel headache because painkiller is not the treatment of migraine. So this is very important to understand this thing on the patient aspect. If we have a lot of treatment for the disease, none must work very well. So migraine is like since human being is there, migraine is there. So there are many researches, many ancient treatment are also there for migraine, and many are not working, many are working like that. So the important thing in management of headache is accurate diagnosis, clear explanation, discuss environmental factors, and general advice to avoid these migraine triggers and few specific treatment. So clear explanation is very important. Many times I told patient that your headache will take some time to relieve, not in a hurry. It is not like painkiller treatment that you take and you will be all right. It can run longer. So clear explanation is very important. So these are the myths, like headaches are caused by defect in visual acuity, headache are caused by emotional upset, all headache are caused by sinusitis, headache are caused by acidity or constipation. No permanent cause, so you have to live with that. Okay. But migraine is often misdiagnosed. So important in a migraine is there are three treatments. One is lifestyle modification to avoid trigger. And then other thing is that you have to avoid trigger. So this is a non-pharmacological treatment. I get a real sharp pain when I do this. So I tell that patient, why you do this? Patient know that if I take lemon juice, I will be having headache. So I tell that you don't take lemon juice. તમને જે વસ્તુથી માઇગ્રેન અટેક આવે છે એ વસ્તુ તમે ના કરો. So this is very important to avoid migraine triggers. So lifestyle important, lifestyle changes are very important. And other treatments are pharmacological treatment. That pharmacological treatment involves abortive treatment. In mild to moderate headache, we can give NSAID, naproxen mainly. And in severe headache, we can give triptans. There are various triptans are available by nasal and oral route and sub-Q also. So these are the triptans for migraine treatment. But most important thing is prevention. So many times people are confused what is the prevention of the migraine treatment. So understand that migraine is not curable, but it is a preventable. So for prevention, the treatment is very important. That duration of the preventive treatment should be at least 4 to 6 months to get some result. I have seen 60 to 70% of the patient on regular preventive treatment like giving flunarizine or long run, patient may have remission in the migraine episodes for 1 to 2 years or many more years. So duration of treatment is very important. And when you start the treatment, you tell that there are some side effects of drugs, but you have to take it because it is better than painkiller, better than taking painkiller daily. So in prevention treatment, patience is the virtue, because sometimes it takes some time to act, like 1 to 2 months, it will start acting. So there are many preventive treatments, mainly calcium channel blocker and beta blockers like propranolol, and some anticonvulsants like valproate, topiramate, gabapentin. But my choice preferable is flunarizine. I start with 5 milligram or 10 milligram, and I continue it for 2 to 3 months. And if patient is not getting result, then I add beta blocker in that. So this is the two drugs which is my drug of choice. If patient is obese and there is no any history of renal stone or glaucoma, then I will also prefer topiramate in young patient because it has some weight loss as a side effect. I least prefer valproate because there is a hair fall and weight gain is there with valproate. So I least prefer that drug. So most commonly I use flunarizine for prevention of the migraine. And understand that preventive treatment should be given at least 4 to 6 months. Okay. By like cluster headache, we can give a few medications. As I told that inhalation of 100% oxygen, then sumatriptan, zolmitriptan, both triptans are effective in abortive of cluster headache. And in long run, we have to give verapamil, lithium divalproate, topiramate, prednisolone, or melatonin. And we give usually tapering dose of prednisolone for initial 1 month for reducing the attacks of cluster headache. So this is the brief about cluster headache. So finally, my story is that jo baka mathu to duke, but don't worry, we are here. We are neurologists to help you for this headache. So never worry about that. We will try our best. Okay, thank you. So now session is open for question answer.
Yes, Dr. Vidal Kumar. Unmute your mic, Dr. Vidal.
I am not able to see any questions here in chat box.
No, sir. We are doing live session in YouTube channel.
Sir.
Okay. So is there any question from audience?
There is question. How can we differentiate the headache of migraine from stroke?
Yes, very important question. Migraine, as I told that migraine is an episodic illness. So there will be a history, which is duration of history is very important. So migraine patient may have history of 6 to 12 months of intermittent headache. While if patient came with acute stroke, headache may be very shorter duration, like 24 hours. If it is a hemorrhagic stroke or any type of stroke, headache can be associated with 25% of ischemic stroke also. So it is not like that stroke not present with headache, but the duration is very important, and it is a continuous, and it may not be a throbbing type of headache. It is a continuous dull aching headache is very important. So this way we can differentiate. And in stroke headache, there may not be a associated vomiting, photophobia, phonophobia, or ringing in the ear, which is very common in migraine patient. And generally, a migraine episode will last for 72 hours, then it will be subside. While stroke headache can be a continuous associated, and there might be associated subtle sign of stroke, like pronator drift, gait disturbances, or definitely some symptoms of stroke are there. So we have to differentiate in this way.
Yes, sir. So what is the persistent headache?
Yeah. So the persistent headache is also known as daily persistent headache or chronic headache. So in that headache duration, or the days of the headache are more than 15 per month. So when patient having a migraine, any primary headache can convert into the daily persistent headache. Like episodic migraine may convert into the chronic headache. Episodic tension type of headache can convert into chronic tension type of headache. Even paroxysmal hemicrania can convert into the chronic continuous paroxysmal hemicrania. So this type of headache is more than 15 days per month, and then it is known as daily persistent headache, and it requires different type of treatment in individual basis. And many times there might be analgesic abuse in this type of headache.
Yes, sir. Dr. Viral Khamar, have you any question? Dr. Viral?
Yes. In our general practice, we have seen that many patients coming with headache complaint as a primary complaint, and when we ask for the investigation, patient is having B12 deficit, and when we supplement this with injections, and patient's headache goes away. So how many cases of headache, or what percentage of headache you think they are B12 deficient, or as a primary cause?
Yes, basically, I forget one point, that there is a comorbidities in migraine patient or any primary headache. They are known as comorbid factors like hypothyroidism, B12 deficiency, vitamin D deficiency, and there might be cirrhosis of liver, or this type of comorbid condition are very frequently seen in migraine patients, especially vitamin D and vitamin B12 deficiency. And there is a large number of studies which associate vitamin D deficiency with tension type of headache. When we replace vitamin D, tension type of headache has very good result. So vitamin D is usually choice of drug in tension type of headache also. And definitely in migraine, there is some association with hyperhomocystinemia, because migraine is basically a vascular type of headache, and hyperhomocystinemia also leads to some vascular changes. So it is seen that hyperhomocystinemia may lead to increased episodes of migraine. So if we replace B12, at least some hyperhomocystinemia get controlled, and there might be leading to improvement in the migraine. But definitely it is not the definite treatment of migraine. B12 is not definitely a treatment of migraine, but as a cofactor or as a comorbid factor, we can definitely replace B12. So it is my usual way to investigate. I will mention headache profile. In that, I investigate with hemoglobin, peripheral smear, thyroid, diabetes, liver, SGPT, and B12 levels. So these are the common accompany in my any OPD patient. So I always take B12 level in this type of migraine patient, and definitely if it comes low, I will give B12 replacement, and it is really helpful for that migraine patient in this way.
Is there any specificity in TIA-induced headache?
TIA-induced.
How can we suspect this is TIA-induced headache?
Yeah. See, basically, TIA-induced headache may be confused with migraine with aura, because only headache in a TIA is very less likely. Generally, in TIA, patient have either sensory symptoms or motor symptoms, but sensory symptoms are usually on the unilateral side of the face. So it is not pure headache, but it is some unusual sensation which may spread on or pass on the one side of the face. hemi location. So this way we can get a headache in TI also, but the duration of that TI episode is 10 to 20 minutes or sometimes up to 6 hours. So, but it's very difficult to differentiate. Sometimes you can check the carotid groove if there is some carotid stenosis, or the cause of TI can be found out, like patient might have valvular heart disease or some other comorbid factors. But in generally young patient, TIA like manifestation can be the aura of the migraine, which precedes with headache. So migraine with aura is 15 to 20% of the patient may have migraine with aura. There might be ophthalmological signs like patient have transient loss of vision. There might be some involvement with sensory symptoms on the one side of the body. So there are many different type of auras. So, but always it precedes with headache. And once aura subside, then headache start. The duration of aura is generally 15 to 20 minutes only. While in TIA, the duration can be 1 hour to 6 hours to 12 hours to 24 hours. So this is the difference between these.
Sir, one last question.
Thank you.
Can migraine cause permanent damage?
Yes, definitely. It is very important. See, migraine is not the headache only. We have that assumption that headache is migraine or migraine is headache. But there are many other things in the migraine. Migraine is basically a chronic neurological disorder. And we have seen white matter changes in MRI of the migraine patient. Chronic migraine patient may develop changes in the MRI. And there are many cases present with ischemic severe stroke after 50 years of age when patient having a migraine history. So there are many other things in migraine, not only headache. So it is there. And there might be some genetic association like hemiplegic migraine or complicated migraine, basilar migraine, when patient may have other symptoms, or patient may have vestibular migraine when there is a not only headache, but there might be tinnitus, vertigo, and hearing disturbances when patient lead to vestibular migraine. So it is very important. These are the subtypes of migraine which I have not discussed. So it is definitely true that migraine is not only headache, it is a chronic neurological disorder which we have to address properly.
Yes, sir. Okay. So we end this question answer session for first lecture here. Thank you, Dr. Shailesh Darji, for giving very lucid and comprehensive talk on headache and covers all the aspects of headache. Thank you very much, sir.
Thank you.
Now I request Dr. Viral Khamar to introduce our second speaker, Dr. Rajeev Harshe. Dr. Viral.
Okay. Yeah. It's my pleasure to invite Dr. Rajeev Harshe and briefing about his biodata. Rajeev Harshe is practicing as the pain specialist at Relief Pain Clinic, Gandhinagar. He did fellowship from prestigious AIIMS, New Delhi, and worked in Apollo Hospital for 12 years. He is an honorary consultant to His Excellency Government of Gujarat. He has authored a chapter in textbook of pain management. He runs Pain Academy and trained more than 26 doctors. He is an invited faculty in national and international conferences. I welcome Dr. Rajeev Harshe to start his lecture on his approach to low back pain. Thank you.
Thank you, doctor. Am I audible?
Yes, sir.
Yeah.
Okay. And there was an issue initially, so I just confirmed.
No.
Yes.
Sure.
Thank you. I'll share my screen. Can you see the screen?
Yes, sir.
Okay. So thank you very much for inviting me to take part in this nice academic deliberation. My subject which I'm going to talk today, is approach to low back pain. Dr. Darji has been very lucid in discussing about the headache, and that really puts me into a little difficult situation that I don't know whether I'll be able to cater that depth which probably Dr. Darji has catered, but I'll try my level best to give clinical approach to low back pain, which we usually do. The first thing is the incidence of low back pain. We know that worldwide, as per the census in 2017, approximately 65 million suffered low back pain. Now you can think, this is 2020. Whenever you come across any patient with low back pain, the first thing I believe is to rule out any systemic reason, because there can be a lot of reasons of low back pain other than the degenerative spine disease. It could include infection, trauma, malignancy, metabolic disorders, etc. If it is there, treat it first. But once you have ruled out those things, now the most common pain generators in the spine, which I'm going to essentially discuss today, are like this. Look to the left side picture, an arrow has appeared. We all know vertebra can be a source of pain. Second, the intervertebral disc can be a source of pain. Behind the disc, you can see a joint called facet joint. So spine is essentially like a tripod, a stool with 3 legs. On the front side, you have vertebra disc stacked up over each other. And on the back side, you have 2 facet joints on either side. So these 3 structures are essentially weight-bearing structures. And these 3 can be a major source of pain. The fourth is the number of muscles which actually help us stand, work in the back. And not to forget, a very important joint, that is sacroiliac joint. The weight which is transmitted through the spine goes through the SI joint to both the legs and to the feet. So SI joint are pivotal joints, and they are definitely important in giving pain. Now, before we jump to anything, some basic things I would like to discuss. Look to the left side picture. You see that when you bend forward, the disc is under pressure. And when you bend backward, the disc is released and the facet joint in the back, they are loaded. So whenever you bend forward, the vertebra and disc are going to be under pressure. And when you bend back, your facet joints are going to be under pressure. This has definite clinical relevance. As we go ahead, we'll know. Second most important thing we need to understand is intervertebral disc has dual nerve supply. One that is somatic, another is sympathetic. The sympathetic chain, if you look to the right side picture, and on the anterior side, anterolateral side, there's a red spot. That is a sympathetic chain. And the sympathetics supply the disc. Similarly, the nerve root which comes out, it also gives sinovertebral nerves, which are somatic nerves. So the intervertebral disc, desi bhasha mein gadi jene kahiye, it has got 2 types of nerve supply, somatic and sympathetic. This too has definite clinical significance, because if we only block one, we may not get results. In order to have good pain relief from the pain arising from the disc, you need to address both of them. Coming to the pain from intervertebral disc, also called discogenic pain. And here on the front side, you can see the disc. So naturally, how it will present? If the patient says, when I bend forward, I get pain. Or when patient sits, patient gets pain. When you sit, usually you are stooping forward, you are bent. You never sit very straight, and that too for a long period of time. When you sit, you tend to bend a little forward, and that puts a lot of pressure in the disc. So that causes pain if the disc is already swollen. On prolonged walking, there is a loading on the disc. pain may refer to the leg. It may or may not be dermatomal. What do you mean by dermatomal? If the pain is going to the proper dermatomes, then it is dermatomal. But the referred pain may not go to the dermatomes. Every disc has peculiar pattern of pain reference, and from that we know that which disc is involved. One interesting phenomena is if you ask the patient to sleep on his tummy and you palpate the spinous process, the disc which is tender, the spinous process at that level is exquisitely tender. What I mean to say is, with the disc which is involved, which is inflamed or swollen, there the spinous process is exquisitely tender. This is a clinical test to know that yes, this is discogenic pain. People have been doing a lot of investigations into putting something in the disc, increasing the pressure and measuring the pressure and telling which disc is actually source of pain. But my 16 years of experience has told me that whenever the spinous process is tender, that disc usually is the culprit. The pain can be bilateral, pain can be unilateral, depending on which side of disc is usually involved. And usually these people feel better in the morning. As the day passes, they start getting the pain, usually in the evening and late night. Second is pain from the facet joint. As we know, we discussed, the pain is, facet joint is situated on the back side of the spine, right? Now, when the person bends back or bends sideways, the facet joints are loaded. If they are inflamed, patient will get a pain. So when the patient gets pain on standing longer, not sitting longer, he will feel better while sitting, and he will get pain if he stands longer. He finds that if he bends back, he gets pain, or when he turns, he gets pain. Another thing is, if you palpate two spinous processes at the level and go little laterally in the middle of them, and if you palpate, there usually there is a tenderness. That is a location of facet joint. So paraspinal tenderness in between two spinous processes, little on the one side. Again, pain can refer to the leg. And usually facet joint pain, like osteoarthritis knee pain, is stiffer back in the evening, in the morning. Vertebrogenic pain. If the pain is arising from the vertebra, we call it vertebrogenic pain. The typical scenario is an old lady, menopausal lady, with osteoporosis, and there is a fragile bone. She lifts her weight, or she falls, or spontaneously the vertebra collapses, and that causes pain. Second is secondaries in the spine, which weaken the vertebra and vertebra collapses. These two situations, typically apart from the trauma, are the reason of vertebrogenic pain, and they behave similar to discogenic pain patterns. But the type of clinical scenario differs, and you can immediately note that this seems to be vertebral pain. Of course, the investigation comes to rescue. MRI is something which immediately helps us to know whether there is a vertebral involvement or not. Pain from the back muscles, also called myofascial pain. We have n number of muscles in the back, and interestingly, they connect the low back to upper back, low back to shoulder. And that is why whenever these muscles are involved, if there is one muscle involved, then automatically all other muscles get involved. It is like an interlinking phenomena. One muscle getting troubled, the other getting trouble, the third getting trouble. And so these patients have typically pain, which is spreading pain pattern with stiffness. There will be local tenderness, and pain will appear according to the peculiar use of the muscle. Usually there is a history of acute injury or repetitive back strain in the form of a person sitting on computer for a long period of time, or person who is driving for a long period of time, right? SIJ, pain from sacroiliac joint, is very typical. If it is a young patient, we have to think of ankylosing spondylitis as the first thing. If it is a elderly patient, we have to think about joint arthritis or secondary pain coming from the spine. These patients have typically unilateral pain. Pain is more on walking, especially they find that if the surface on which they're walking is uneven, they fear walking. They cannot sit cross-legged. That induces pain. Generally, there is no tingling in the leg when there is a sacroiliac joint involvement. But if piriformis muscle, which is attached or close to this joint, is also involved, then that presses over the sciatic nerve, which passes under the piriformis, and patients may get some tingling in the leg. Now, how to treat discogenic pain? Remember, whether it is discogenic, facetogenic, vertebrogenic, the first and foremost is conservative treatment. If the conservative treatment fails, then only we go for some intervention. And if the intervention fails, then comes a surgery into the picture. So this is a broad standard guideline which we follow. So first thing is give him rest. Ask him to avoid a lot of forward bending or lifting weight while forward bending. Avoid prolonged sitting. Give him routine analgesics and neuropathy medicines. By neuropathy medicines, I include gabapentin or pregabalin, tramadol and paracetamol, and amitriptyline. Why? See, chronic pain is different from acute pain. In chronic pain, there is a hypersensitization of peripheral nerve, dorsal horn, and even at times the brain. Here, your NSA doesn't work longer, or it may not work at all. Paracetamol and tramadol are the molecules which work to prevent the hypersensitization. Amitriptyline or tryptomer in very low dose in the form of 5 milligrams at night, it stimulates the descending inhibitory pathway in the spinal cord, and they prevent the pain from increasing in intensity and duration. So tryptomer has got definite role in very low dosages. If there is no pain relief, then in discogenic pain, we have plethora of treatments available. But since there was a limitation in time, I have selected the most common 3 line of managements which are routinely practiced. You see the left picture. I've written ozone nucleolysis. Now what it is? The disc is what? The center is a jelly-like material which actually takes the shock. And the periphery is a hard fiber which prevents the inner jelly to come out. Whenever there is a cut in the outer fibrous margin, the inner jelly pulls out, and the nerves are there in the peripheral fibrous tissue only. So patient starts getting severe back pain. What we can do under the fluoroscopy, live X-ray guidance, we put a needle right into the disc and inject ozone. Ozone dehydrates the disc, and so it prevents further migration of the semi-liquid jelly-like inner material to go to the periphery, and this prevents the further stimulation of the nerves and prevents the pain. This has dual advantage. One, it relieves the pain. Second, it prevents the further sciatica which would have occurred if in this situation patient undertakes another strenuous activity. The minor side of this is if you have to go for discectomy, ozone dries up the disc and it makes it hard. So if there is an ultimate goal to do the surgery, probably he may have to do little hard work. That's it. Second is disc effects. Now see the central picture. What is disc effects? In disc effects, a small needle is passed, and over it by railroad, we introduce a cannula through which the forceps goes, and we remove a part of the disc. Here, we are not actually visualizing it directly. We do alternate. We visualize remove the visualization tool, and then put the instrument and remove the disc. And third, on the right side is endoscopic discectomy, in which there's a continuous visualization, and under the live visualization, a part of the disc is removed. But ultimately, this is a surgery. And somehow we have seen that those patients who are not ready for surgery, ozone nucleolysis works wonders, provided it is a contained disc. What do you mean by contained? Contained means the disc material has not leaked out. Whenever the nucleus material has leaked out, there is no increase in pressure in the disc. So there is no need to relieve the disc pressure. There will not be any discogenic pain, right? Now coming to the facetogenic pain. Again, the same line of management which I said. Here, the non-specific anti-inflammatory agents do have some role to play. Some people have even tried glucosamine along with analgesic agent, which is a off-bit approach, but it has given results in some patients. Regarding the treatment or intervention which we do for facetogenic pain, on the left side, you can see that under fluoroscopy or live X-ray guidance, a needle goes into the joint and we inject steroids. This reduces the inflammation and reduces the pain. Second option is, at times the joint is so degenerated, we are not able to go inside, or we want prolonged effect. In that case, see the right side picture. It's called RF ablation of nerve to facet joint. Basically, every joint is supplied by two nerves, one from the same level and one coming from a level above. So what we do is we try and locate those nerves and ablate them with radiofrequency ablation. This gives prolonged pain relief. Here, the typical scenario is patients may get pain for a month or so, and then there is a prolonged pain relief. There may be some soreness in the back for a period of time because of RF. Treatment of vertebrogenic pain, mostly conservative, but if needed, there are two special interventions which are done routinely. On left side, you see a vertebroplasty. What is done in that? We put a needle through the pedicle of the spine and go inside the vertebra and inject the medical grade bone cement. This, when solidifies, it does two things. It emits heat, so it seals all the nerves of the vertebra and reduces pain. And when it becomes solid, it gives support. On right side, you see kyphoplasty. This is a different technique in which once you pass the needle, then a special inflatable balloon is inserted inside the vertebra. The balloon is enlarged. This creates space in the vertebra, and then that space is filled with bone cement. They say that this has an advantage over the vertebroplasty in that there are less chances of vascular uptake, A, and it gives a lot of room for the cement to keep locally. Only thing is, whenever the posterior surface of the vertebra is broken, this treatment is not undertaken. Even the height of the vertebra does not allow the needle placement or placement of cement. This is not useful. But this is done in very, very, very selected patients. Myofascial pain. Again, after conservative treatment, we can inject the muscle under live ultrasound guidance. On the left side, you can see that the probe is put, and on the right side, you can see that the arrow is showing the needle entering the muscle. So you can see the muscle, you can see the needle, you can see the fluid being injected. And this has fantastic use in usual pain management practice. Sacroiliac joint pain. After the conservative treatment, there are two modalities which we use. On the left side, you can see that the arrow, red arrow, is showing the lower end of the sacroiliac joint. Sacroiliac joint is what you can see as two black lines going up and a white shadow in between them. That is the SI joint. And on the lower end, you can see a black needle entering the joint. This is called sacroiliac joint injection. We usually inject steroid in the joint. Sometimes we ablate the nerves to the SI joint. So right side, you can see RF ablation of the nerves of the sacroiliac joint. If you see the picture, the black lines which you see on the right side are basically the nerves going to the sacroiliac joint. You can see the sacrum, ileum is not shown, and it is presumed that right side junction is sacroiliac joint and the nerves are entering the joint. These nerves individually picked up and RF ablation is done. This gives prolonged pain relief. Now comes a basic question. Can we prevent pain? Yes, we can. In a person who is doing regular office work, one must follow office ergonomics. Ask your patients or colleagues or friends to go to the Google image and write office ergonomics, and you will see this picture. This picture tells volumes. Number one, the person is sitting straight with complete back support. It should be there. Second, his seat is supporting his 70 to 80% of the thigh. It should not be less or more. If the seat is too deep, you have to put a pillow behind. And if the seat is too shallow, you better remove that chair. Then when you sit, your foot should be completely on the floor. Not that you have only fingers touching the floor or even your heel touching the floor, but you can't put your fingers, right? So height of the chair should be equal to the height of knee to the heel. The screen should be at the eye level. Your arm, when you type, should be fully supported. So these all things matter when you work longer. Nowadays, when people are doing work from home, people are doing all nonsense, sleeping on the bed and typing on the laptop, or sleeping in the sofa with legs on the teapot and working for hours together. This usually gives neck strain, low back ache, arm pain, wrist pain, etc. So office ergonomics, if followed, helps a lot. Second, the most important thing is when you want to lift the weight, never lift the way it is done on the left side. You don't simply lift weight like this. Look to the right. He has bent his knee. What he does is he is offloading the weight from the back to the knees as well. So his knees are also supporting. His muscles of the legs are also supporting. This prevents disc prolapse. Third thing is, usually nowadays people, they straight away go to the gym and start lifting the weight. Most of the time, these are the people who come across myofascial pain or disc prolapse. A complete and proper warm-up under the guidance of a coach is a must before you undertake any exercise, may it be gym or any other exercise. This will prevent back pain. And fourth, not the least, do regular yogasana. I have seen, I'm 59. I had some low backache. Since last 2 years, I'm doing regular yogasana. Not only that, I'm proponent of that. I have created half an hour video for yogasana protocol and I put on YouTube so that anybody and everybody who wants to see and follow it can do it. And believe me, number of people have followed it and told me that their pain is gone. So if you do regular yogasana, it stretches your muscles, it keeps them supple, and it does help in prevent back pain. So the conclusion is prevention is better than cure. Most of the time, simple treatment helps a lot. There's no need to have rocket treatments for every another back pain patients. Interventions are, to my feeling, hardly required in 5 or 10% of the patients. Even that I'm probably telling little higher. Understanding the pain and diagnosing it correctly is more important, so that we can guide him correctly. And in those refractory patients, yes, interventions do help. Thank you very much. I think I tried to do justice to the subject.
Yes, sir. We proceed for the question answer session.
Yeah, sure.
Yeah. So one question is, which is better, the MRI or CT scan for low back pain?
See, CT scan is useful when you want to see the bones only, but MRI shows soft tissue. So disc, nerves, muscles, they are better visualized in MRI, and that is why we advise MRI only.
Yes, sir. Sir, what is the difference between the sciatica and radiculopathy?
Beautiful question. See, radicular pain is basically pain coming from the spine when the nerve is pinched in the spine, right? Now, sciatic nerve can be pressed because of piriformis also. I said that in the sacroiliac joint, I mean behind the sacroiliac joint, the muscle called piriformis muscle. If this piriformis muscle is tight, I didn't show the slide, I forgot to include that slide. There's a beautiful slide which shows that the sciatic nerve can pass through the piriformis muscle, above the piriformis muscle, below the piriformis muscle. So whenever there is a sacroiliac joint pain and piriformis stretching, it causes pain, right? Going to the leg. Then even buttock muscles, when they are tight, they tend to press the sciatic nerve and you get pain. So sciatica is a layman term for the pain going from buttock down to the leg in the sciatic nerve territory.
Yes, sir. Dr. Viral Kumar, have you any question? Dr.
Yeah.
Viral.
Sir, we have found that many patients who are obese comes with the complaint of sciatica. So reducing weight will relieve the sciatic pain to some extent or completely?
See, basically, overweight is definitely itself is it's a disease, right? We know that it puts a lot of stress on spine, sacroiliac joint, knees, muscles, everything. So the moment you reduce the pain, definitely it helps to relieve the pain. Only thing is, before telling that every another pain a obese patient has will go away simply by reducing pain, will be a little overstatement, because we have to find out the reason of pain. Maybe in 70 to 80% of the cases, yes, what you makes sense. If you ask him to reduce the pain weight, it goes away. But you and me know, people hit the gym, people hit the road, and weight reduction is not a simple thing. It doesn't go away immediately. So they have pain with which they live. So first thing we have to do is give him some pain relief, give him some sort of exercises, ask him a way of life which can prevent exacerbations. And then meanwhile, he may go for weight reduction, and probably that will help him a lot. And if we know that, no, there is something which we have to address, then probably a small intervention somewhere and then doing all these things can be helpful.
Uh, which one you prefer, pregabalin more or gabapentin more?
Both are good. Both are good. Pregabalin is a newer molecule, but some people still believe gabapentin gives them result. It is probably a personal predilection. We use it in neuropathy pain only. When we are sure it is neuropathy pain, then only we start, and start very low. We come across patients who have been referred by some other interior doctors who have given 400 gabapentin 3 times a day, and patient is literally drowsy, irritated. And one another thing which I would share is patients over 60, probably 70, they go sodium deficient immediately with pregabalin and gabalin both. And they start speaking irrelevant, going into fast, and those kind of things. The moment we give them sodium and withdraw the medicine, they feel good. So I have a word of caution here: pregabalin or gabapentin. start low, go slow. You may take some days to get the relief, no problem. But if you hit the road, he will either fall and have problem, or he will go Jackson.
So, in herpetic neuralgic pain, which molecule you prefer?
Usually I prefer pregabalin, and in that case, post-herpetic neuralgia is a tough nut to crack. So what I believe is, no doubt, pregabalin, amitriptyline, ultracet, or tramapera has definite role to play. But along with that, don't forget, either repeated local anesthetic block of the nerve, or once local anesthetic with steroid block of the nerve helps a lot, because essentially it breaks the hypersensitivity, hypersensitization, right?
Okay.
We have seen that if you do that, later on they recover far much better rather than just putting onto medicines longer. So one block and then think.
Sir, I have two questions. One is there any concern of pregabalin leading to dependence or any other cardiac or such side effect on long run? Like I have seen patient taking pregabalin for 1 or 2 years longer because of some dependence or that type of physical dependence. Second question is when to refer a patient with chronic low back pain for surgical intervention or any type of surgical approach when patient came with low back pain, which are the signs or which symptoms we have to consider? These two questions.
Red flags. Red flag. You are talking about red flags. You're talking about red flags. Yeah. Yeah. As a first is, if you have any systemic reason, send it to the right person. Number one. Number two, if there is weakness in the limb, if there is loss of sensation in the limb, in the part of the limb, if there is a bowel or bladder dysfunction, these four are the red flags which I never touch. I simply say, neurosurgeon is your right doctor, I will not touch. Even if they have early signs of hyperplexia and you see the sign shows myelomalacia, never touch them. Send it to the right person, because you are not doing anything good, but you are doing the treatment.
Yes, sir. Thank you. One last
Your talk
question.
was nice.
One last question. How can we differentiate the back pain is due to muscle strain or due to disc herniation?
Right. See, disc herniation, if it is not broken, will give backache. But disc herniation, if it is broken and out, then they will not be low back pain, because back pain from the disc, excuse me, sorry, back pain from the disc is only there when there is an increased pressure in the disc. The moment the material has leaked out, the back pain will go away and patient will have leg pain. Number one. And what was your question? I forgot. I got diverted.
Yes, sir. Differentiation between back sprain or due to disc herniation.
See, clinically, if you want to ask me, in myofascial pain, patient will not have the typical discal spinous process tenderness or spinous facetal tenderness. He will have myofascial tenderness. Number one, the history will be important. Third, there will not be a radiating type of pain. Usually, discogenic pain refers to the thigh, outer the leg. Similarly, facetal pain refers to the buttock or back of the thigh. The myofascial pain is usually local, usually induced by peculiar activity, and the history will also give a lot of clue.
Dr. Viral Kharma, have you any question?
No.
No. So we conclude the session here. And thank you, Dr. Rajeev Harse, for delivering a very informative talk on low back pain, simplest way. It is useful in our day-to-day practice. Now we proceed for the vote of thanks. I am thankful to both the speaker, Dr. Shailesh Darji and Dr. Rajeev Harse, for sparing your valuable time for our association. I am also thankful to moderator, Dr. Viral Khamar, for joining with us. And we also thankful to Johnson & Johnson Pharma people, Mr. Harish Trivedi, area manager, for arranging today webinar. And thanks to all the AP and GSFPF members for attending the webinar. Again, I remind you all that please join in the strike against the mixopathy tomorrow and make it successful. Thank you.